of the New York State WIC Training Center. I just want to take a few minutes before we begin to go over some logistical pieces quickly with you. And that's making sure that you're aware that we record all of our live webinars, as I said. That is for the purpose of storing them on the on-demand page of the New York State WIC Resource Hub. So if anyone wasn't able to make it, some new staff come on board, they'll have access to view the recording of this webinar at their leisure. All of the resources we share throughout today's webinar, including a copy of the PowerPoint slides, will be made available on the New York State WIC Resource Hub when the recording is posted. So you will have access to that. Don't worry about jotting down too many notes. We'll give you access to that. And just a reminder of our policy, you must register in the New York State WIC Resource Hub in order to attend today's webinar. If you didn't, you're not going to have access to the evaluation and certificate. We do need to make sure that the name you joined, your Zoom name, matches the full first and last name that you registered under. We do physically mark everyone attended because attendance comes from a different place in Zoom. So if your name isn't your full first or last name, not to call anyone out, but a few examples like a BAUL5, Elka, anyone that doesn't have a full first and last name, if you can rename yourself to make sure that it matches the name you registered under, that's going to give us the ability to mark you attended and give you the ability to get your certificate in continuing education for being here. Anyone that misses 15 minutes or more of the webinar will be asked to view the recording at another time. We're going to close the Zoom door, so to speak, at 15 minutes after the start time today, and no one will be permitted in after that time. We're covering a lot of content in 2 hours, and missing 15 minutes is a rather large chunk of that. So if you're missing a large chunk of that, and we understand things come up, we just ask that you view the recording instead. We will be together for the next 2 hours, 2 to 4 p.m. We do not have any planned breaks, so practice self-care as you need. If you need to get up and use the restroom, a phone call comes in, we totally understand. Just make sure you're keeping that to a shorter time. And 2 hours is a long time to sit, we know too. So, stand, stretch, do whatever you need to do. And I do want to remind everyone also that at CAI, we support breastfeeding. If you're nursing and need to step away to pump, just chat us and let us know that you'll be gone for an extended period of time. Policy is waived for those who are nursing, but it's important that you just inform us if you do need to step away. And on the next slide, you'll see that this training was developed through a collaborative contractual relationship with the New York State Department of Health and CAI, Chickatelli Associates Incorporated. Funding for this training is provided by USDA, and you'll see some contact information for both the WIC Training Center and DOH on screen. Again, you don't need to worry about jotting these down, as a copy of the PowerPoint will be provided to you. And another reminder that immediately following the policy section of each policy in the WIC program manual is the regulations section, which either includes direct links for reference or lists the complete regulations. The Food and Nutrition Service provides assistance to state agencies and evaluates all levels of program operations to ensure that the goal of the program is achieved in the most effective and efficient manner possible. So now I want to welcome our staff on today's webinar. Our first presenter is Deb Campbell, Doctor of Medicine and Fellow of the American Academy of Pediatrics, Professor of Pediatrics and Associate Professor of Obstetrics and Gynecology and Women's Health at the Albert Einstein College of Medicine, and an attending neonatalist at the Children's Hospital at Montefiore, having formerly served as Division Chief. Dr. Campbell has an active role in perinatal activities at the New York City, state, and national levels, and is an editor of and contributor to several American Academy of Pediatrics publications, including the Textbook of Pediatric Care Online, the Quick Reference Guide to Pediatric Care, Neonatal Care, a Quick Reference Deck, and Neonatology for Primary Care. So not busy at all, right? I also want to allow my coworker, Maria Dentino, our Nutrition Training and Development Specialist, to introduce herself.
Hi, everyone. My name is Maria Dentino. I'm a registered dietitian and certified lactation counselor. I have been working with the WIC program since 2008, and I'm currently the Nutrition Training and Development Specialist at CAI, and I'm really excited to be here with all of you today.
Thanks, Maria. And we're also joined by Kat Smith, our producer. You probably know her and recognize her. If you have any technical difficulties throughout the webinar, need any help locating any of the Zoom features, go ahead and chat Kat and she is happy to help you. And if you need to chat me, you can do so as well, and I'm happy to help. I do want to share that none of our speakers today have any disclosures to share with you. We just want to make sure you're aware of that. And now that we've gotten that out of the way, let's dive into our content. So I just want to let you know, as a recap, part 1 discussed the perinatal parent experience with preterm birth and how we can collectively support parents whose babies are in the NICU or transitioning to home and community. Today's session builds on those ideas shared in the pre-recorded webinar, so if you haven't had a chance to watch it yet, we suggest giving that a look in the New York State WIC Resource Hub on the on-demand webinar page to deepen your learning of today. And now I'm going to turn it over to Dr. Campbell to go over today's goal and get us started.
Thank you very much, and thank you for the kind introduction and the opportunity to meet again with the group. So the goal for today is to really continue our review of the comprehensive aspects of neonatal nutrition and parent support for preterm infants who require neonatal intensive care. Next slide, please. The learning objectives for today are to examine the nutritional needs of the preterm infant, who, as I mentioned, does require neonatal intensive care, discuss human milk feeding, breast pumping, and the transition to breast or chest feeding while in the neonatal intensive care unit, as well as, next slide, describe discharge nutrition planning and post-NICU nutrition for the preterm infant. Also explore tools for monitoring growth and identifying support and resource needs for families of preterm infants in the community. Next slide, please. So we're going to transition now to just a brief overview to review some of the content from the first session. And if I could have the next slide, we're going to be focusing on just reviewing some of the terms that we discussed last time, as well as some potential health considerations for the preterm infant. So our first poll question is, how many weeks gestation is an early preterm baby? The choices are less than 28 weeks gestation, less than 34 weeks gestation, or 34 to less than 37 weeks gestation. So you can click on one and submit your answer. Okay, so we have a fairly equal distribution with most of the respondents identifying either less than 34 weeks and others selecting 34 to 37 weeks with a smaller percentage choosing less than 28 weeks gestation. So I know that this was content that was detailed and a little complicated when we went through it the last time. The correct answer is actually the second choice, less than 34 weeks gestation. So if we can go on to the next slide, please, we can review that information. So this was the graphic that we shared last time, and it is complicated. As a reminder, a full-term pregnancy is typically 40 weeks of gestation, and we break down the gestational weeks, either categorizing them as preterm if the infant is born less than 37 weeks completed gestation, and full term if the infant is born 37 to 41 weeks gestation. Within the full term, although that's not the focus of today's talk, we do break down those infants to early term, so 37 weeks through 38 weeks completed gestation is considered early term. And we just note that because some of those infants will also have some specific nutritional needs, as well as sometimes some feeding challenges. Reviewing specifically about preterm infants born less than 37 weeks, if you look at the medium purple colored columns, we have late preterm, which is 34 weeks and 0.7 days through 36 weeks and 6/7 days. those infants are considered late preterm. The early preterm group are the infants, as we said, less than 34 weeks. And within that, we also have two subcategories. And this certainly adds to sometimes the complexity of thinking about the different babies and their particular risk factors. But we have moderate preterm. Those infants were born at 32 weeks, 0 days through 33 weeks and 6/7 days. And then infants born between 28 weeks and 0 days through 31 and 6/7 weeks are considered very preterm. Less than 28 weeks gestation is extreme preterm. So it does get complicated, but sometimes just having this chart as a reminder can help you think about, the baby that you're caring for and what their potential concerns might be. Next slide, please. The other reminder is that we also focus on birth weight categories. Babies are considered what is referred to as low birth weight if they weigh less than 2,500 grams or 8.5 pounds at birth. They're also considered very low birth weight if they happen to weigh less than 1,500 grams, which is 3 pounds, 5 ounces. Extremely low birth weight is another category, again, of a smaller, tinier baby who weighs less than 1,000 grams at birth or less than 2 pounds, 3 ounces. And the smallest category that we talk about are micro preemies or nano preemies, depending on where you are in the country. But those are the infants who weigh less than 750 grams or less than 1 pound, 10 ounces at birth. The schematic at the right is just to remind us that not only are we looking at birth weight in terms of categorizing whether the baby has a normal birth weight, a low birth weight, very low birth weight, or extremely low birth weight, but also plotting the baby on the newborn birth curves to be able to tell us whether the baby's growth is appropriate for their gestational age. So if you just look within those waved lines, that middle line where it's marked appropriate for gestational age, I don't know if can I have a marker. I don't know can you see the pen or?
No.
No, okay, all right. So if you look between those two curved lines, it says appropriate for gestational age. So, and you see how that as the gestational age moves from lower gestational age to more mature ages, the curve increases along with corresponding increases in weight. And a baby who's born between the 10th and the 90th percentile is considered appropriate for that gestational age. Babies who are above that are considered large for gestational age. Babies who are below that are classified as small for gestational age. Next slide, please. As we think about preterm infants, we do have to consider the kinds of vulnerabilities that they have and potential complications that they may experience. In the NICU, some of the complications that we see related to preterm birth, particularly those infants who were born very preterm, so less than 32 weeks, or especially those infants less than 28 weeks gestation. The risk for developing chronic lung disease of prematurity, also referred to as bronchopulmonary dysplasia. Renal insufficiency, all the organs will be immature to some degree. Certainly the more immature the infant is gestationally, the more immature the organ function. And as a result of that, the babies can have significant complications related to their early birth. Short bowel syndrome is a complication. Certainly it's one that we see more rarely, and it usually is associated with infants who've had significant intestinal disease requiring surgery and removal of large portions of their intestine. Osteopenia prematurity really relates to what we also refer to as metabolic bone disease, or sometimes rickets of prematurity, and it's due to inadequate calcium and phosphorus intake nutritionally. Oftentimes is associated vitamin D deficiency. Anemia of prematurity, again, after a baby's born, it takes about 6 to 8 weeks for their bone marrows to really rev up and start producing new red blood cells on their own. And in that period, just with the amount of blood testing that goes on, the rapid growth that the infant requires, anemia is very common. And then we certainly have concerns about the risk for potential severe neurologic injury that may be related to either bleeding in the brain, blood flow issue, difficulties that result in what are called ischemic injury to the brain and other abnormalities. In addition to the kinds of complications that we can see in preterm infants, some babies will also have what are referred to as comorbidities. What we mean by that is anywhere from up to about 5% of babies may have a birth defect at the time they're born, so that a baby who's also preterm is also at risk for that as well, and sometimes related to the underlying congenital malformation or potentially syndrome that they have, they're much more likely to be born preterm. So particularly the potential morbidities that we also have concern about are those babies who may have congenital abnormalities of their intestinal tract or have congenital heart disease, because those certainly impact growth, nutrition, and the support needs of the infant. We also have to always be mindful about potential environmental factors. Some infants were exposed in utero to substances, alcohol, sometimes environmental toxins as well. Certainly we know, and we spend a lot of time now focused on the social drivers of health, and two very important ones relate to poverty and low socioeconomic status, but that really is, again, a proxy for sort of neighborhood poverty, lack of resources, more limited opportunities that impact the health and well-being of the pregnant patient. Next slide, please. So expanding a little in terms of the longer term health problems for preterm infants, as we mentioned, when we think about the gastrointestinal system, we have to be mindful of the risks for nutritional deficiencies. So this is not only in terms of the need for more calories to support growth, the need for proper amounts of protein intake, as well as nutrients, calcium, phosphorus, salts in terms of sodium intake to support optimal growth and to support healing. Gastroesophageal reflux is actually very common. All infants will have some degree of reflux. And in particular, for the preterm infant, this can be particularly challenging because it can further impact their ability in terms of tolerating either nipple feedings or tube feedings, and can impact their growth as well. And certainly, as I mentioned before, those infants who may have needed surgery because of necrotizing enterocolitis or some other intestinal condition where the intestine itself is damaged or needs to be shortened because of an abnormality, that then can contribute to nutritional deficiencies that further compound the underlying risks that we see just related to prematurity. As we think about physical growth, we spend a lot of time focused on feeding difficulties, both while the baby's in the NICU and even after discharge, that can contribute to inadequate weight gain, incomplete catch-up growth, both in the short and the long term. And we're also seeing among preterm infants that babies who are born prematurely or babies who are small for gestational age, if they experience rapid weight gain in early infancy, they are at higher risk in childhood and adolescence and adulthood for metabolic syndrome. It's felt to be related to sort of changes that happen in terms of developing insulin resistance that happen very early on, that predispose infants who are born preterm or small for gestational age to later abnormalities associated with metabolic syndrome, also in terms of hypertension developing earlier in life. As we think about oral health, and that certainly is very important to effective feeding and optimal nutrition, preterm infants do tend as a group to have delayed tooth eruptions, so they may not start to teeth at 6, 7, 8 months. It may be closer to a year. And more commonly, concerns with tooth enamel hypoplasia. That is really caused by undermineralization of the enamel coating of the first teeth. And it's usually due to a combination of nutritional deficiencies, inadequate calcium and phosphorus, as well as sometimes for some of the babies, the medications that they're on that actually also cause loss of calcium and phosphorus. So that they're not able, the teeth don't develop properly. What that looks like is when the teeth do erupt, they're oftentimes misshapen. They may have brown patches or spots on them, and those are the areas of the enamel hypoplasia. So you're actually seeing the dentine of the teeth as opposed to the protective enamel over them. Next slide, please. Okay, we're going to spend a little time now focusing on nutrition and feeding for infants who require neonatal intensive care. Nutritional considerations do vary by the infant's gestational age and degree of immaturity. Certainly the birthing parent pregnancy conditions that can impact the baby's health and nutritional needs. Certainly a birthing parent who may be needing to manage diabetes in pregnancy or may have pre-existing diabetes. Hypertensive disorders, either gestational hypertension, preeclampsia, the more severe cases that lead to eclampsia or maternal seizures. Also chronic hypertension, certainly in many of the families that we care for. There are high rates in the community of both diabetes type 2 as well as chronic hypertension, so that this is a risk both to the pregnant patient as well as potentially to the infant, and particularly when it relates to hypertensive diseases of pregnancies or hypertensive conditions of pregnancy. That is a very common reason for preterm delivery. So certainly for those of us providing care in the NICU as well as for WIC nutritionists, it's important to have an understanding not only of the NICU experience, but some of the challenges that we have in terms of optimizing nutritional intake and growth in our babies. Next slide, please. So the NICU journey for a premature infant, it can be quite complex. And as I mentioned, will vary by the degree of prematurity as well as the range of medical problem the infants experience. Certainly one can have a baby who might be a moderate or late preterm infant whose birthing parent had a extremely complicated either pregnancy or delivery course and who is quite ill at birth. While certainly we know that the very tiny preemies, those born at 22, 24, 26, 28 weeks, just related to the extreme degree of immaturity, will be quite ill as well. The initial issues oftentimes will involve transition from the intrauterine environment to extrauterine life. Certainly immaturity of lung development, immaturity of control of breathing. These have associated risks in terms of risk for chronic lung disease. We also have in terms of infants who as related to the immaturity of control of breathing. This is one of the common reasons why a NICU course may actually be prolonged, even if a baby has reached readiness relative to the other criteria in terms of ability to maintain temperature and ability to feed fully by mouth, either breast or bottle feeding, is the residual immaturity, so that the babies will have what's referred to as apnea prematurity, where they'll have respiratory pauses that may be associated with drops in heart rate or bradycardia, or drops in the oxygen saturation referred to as desaturations. As we think about the brain in a preterm infant, the brain's most rapid growth occurs during the third trimester, so that between 27 and 40 weeks of gestation, the brain weight and size is increasing 5 to 6 times. And if you think about how much that entails, how much activity is going on in the brain, certainly very important in terms of brain development, but also speaks to the vulnerability of the brain during this time to brain injury. Brain bleeding is very common in the preterm infant. Certainly with current therapies and approaches, practices, and care, it's much less common than it was 20 to 30 years ago. But we still see a number of babies who will have some degree of what's called an interventricular hemorrhage in the first weeks of life. We also certainly have difficulties early on with temperature regulation, and the temperature instability may persist through 34, 36 weeks of gestation, or what we refer to as postmenstrual age for a baby who might have been born at 24, 26, 28 weeks. Then that when they reach 34, 36 weeks of development, and we're trying to transition them out of an incubator into an open crib, they may have difficulty. And really, there are infants that go home and may have difficulty maintaining their temperature at home and might need readmission. Other kinds of challenges we have in terms of caring for the preterm infant, what's called hyperbilirubinemia or jaundice of the premature newborn, metabolic abnormalities in terms of managing glucose and calcium, and there's also a higher risk for infection. So you can see from this that clearly, in terms of thinking about brain growth, thinking about organ growth, you can, next slide is fine. Thinking about organ growth and development, all of that becomes is tied very strongly to our ability to adequately nourish the babies, and the kinds of complications they're experiencing may impact our ability to do that as easily as we would hope. So nutrition is crucial, and certainly not only in terms of growth, but in terms of development, in terms of long-term cognitive outcomes, optimizing nutritional intake and correcting deficits. Babies very quickly, especially the preterm infant, will very quickly show deficits, both in terms of caloric deficits as well as protein deficits. So that at the time they go home from the hospital, they oftentimes will weigh up to 1.5 to 2 pounds less than a baby who was born at term. And that we see the same thing impacting other aspects of their growth at times. So feeding difficulties is something that's part of our day-to-day existence. It's due in part to immaturity of the oral feeding skills, with immature coordination or lack of coordination of what's called the suck, swallow, breathe triad, which really needs to be in sequence so that the baby can feed efficiently. And all these infants also, again, have very limited endurance. So again, they will need feeding therapy. And oftentimes, if we're following the infant's cues and their abilities to be able to feed, we really have to tailor what we're doing to really support them optimally and actually prevent worsening suboptimal growth and other difficulties. In addition, when we think about caring for these infants, oftentimes, as I mentioned, these babies may have are at risk for anemia prematurity. Many will need blood transfusions. All will need iron supplementation. They'll need specialized nutritional support at the beginning in the form of intravenous nutrition, also called parenteral nutrition or total parenteral nutrition. And then as they start tolerating enteral feeds, optimally human milk feedings, they often will need fortification for a period of time, again, to try to correct those caloric deficits as well as the protein and other nutrient deficits that we know that they experience in the early weeks to months after birth. Very preterm infants are also more susceptible to infection because of their immature immune systems. And as we've talked about before, and we'll continue to focus on, issues related to immaturity of the gastrointestinal tract are an ongoing challenge for the babies. Next slide, please. I think you went backwards. One more. Okay. So there are many, many factors that affect postnatal growth of babies in the NICU. A few of the important ones, certainly the focus or paying attention to growth parameters at birth. The growth centiles, if you remember the slide from the beginning of the presentation, that sort of helped us get a sense of the appropriateness of the infant's growth at the time of birth. As we plot their weight, length, and head circumference on the preterm infant growth charts, we're able to assess whether that child is appropriate for gestational age, small for gestational age, or large for gestational age. In addition, for those infants who may be small for gestational age, knowing the pregnancy history and what the fetal growth was like over the course of the pregnancy also gives us important information, because we'll have babies who may have sustained a longer period in utero with suboptimal nutrition, and that infant oftentimes is more likely to be what we call symmetrically undergrown. And depending on the degree of small for gestational age, the percent, usually we say SGA is less than the 10th percentile, but we have babies who may be born below the 3rd percentile or below the 1st percentile. And oftentimes those are infants whose birthing parents have had long courses with chronic hypertension as well as superimposed preeclampsia that affected fetal growth throughout the pregnancy. Certainly, another group of infants that are vulnerable to that symmetric fetal growth restriction are those babies who may also have congenital malformations or underlying chromosomal disorders. In addition, we spend a lot of time focused on the baby's glycemic control, making sure that their blood glucoses are in the normal range. One, because you need to have blood sugar in a normal range for optimal brain functioning in a preterm infant, as well as certainly providing some of the calories that they need for growth. Babies, especially the preterm infant, very quickly depletes their sort of internal stores of glycogen, which is a storage form of glucose in the body. So again, this can lead very quickly to adding to the nutritional deficits of the infant. And then also in terms of, as we think about mineral and nutrient deficiencies, the stores at birth are quickly depleted. The 3rd trimester is really a period of what we call mineralization. So the fetus is getting from the birthing parent really continuous infusion of calcium and phosphorus and magnesium, all the things and other nutrients and that they need for bone mineralization, for healthy growth and development. And when a baby's born prematurely, that continuous flow of nutrients is cut off. And we have to try to find ways to replicate what the baby would have gotten if the baby were still in utero. Next slide, please. We've mentioned several times the importance of immaturity of the gastrointestinal system, again, until a baby is able to tolerate feeds and we're able to get to full enteral feeding, either by bottle or typically early on through nasogastric tube feedings. We oftentimes have to rely on parental nutrition, so that it really is a nutritional and medical emergency for these babies to be able to really start appropriate nutrition as quickly as possible. And because of their gestational age, their growth assessment, the degree of prematurity, as well as the level of illness, the calorie, protein, macro and micronutrient needs are oftentimes quite increased. Next slide, please. I alluded to before that we have criteria in terms of discharge readiness for our babies. Certainly just from the standpoint of the baby, we want them to be able to maintain their body temperature in regular ambient conditions. So in a crib or a bassinet with baby clothes, a snuggly, a sleeper on, that the baby is able to fully feed by breastfeeding or bottle feeding, and it may be bottle feeding formula, breast milk, a combination with consistent weight gain, and that the baby is able to breathe independently. Although very rarely an infant might go home with a nasal cannula and a little bit of supplemental oxygen, the vast majority of preterm infants will be going home without any respiratory support. Next slide, please. Feeding difficulties are very, very common. And again, related to the complexity of the baby's underlying health conditions, their ability to coordinate, suck, swallow, breathe, associated conditions such as gastroesophageal reflux, babies with apnea, babies with chronic lung disease. We know that that increases their metabolic requirements as well as decreases their endurance and their ability to feed easily. That's oftentimes we can sometimes run into difficulties with inappropriate feeding regimens. Less so in the hospital because we tend to be a little bit more prescriptive, but certainly at home and sometimes even in the hospital, because a lot of these babies will be getting feeding therapy, and the feeding therapist will have very specific guidance around using cue-based infant-driven feeding with co-regulation, and I'll explain what that means. And sometimes not even allowing a baby to nipple every feed may suggest just giving a small volume a few times a day to help the baby build their skills. But sometimes staff will feel, oh, the baby wants more and can take more, and that can result in sort of inappropriate feeding approaches that actually slow the baby's progress rather than foster a time to achieving full nipple feeding. That can contribute to poor or slow growth philosophy, increased energy expenditure, and oftentimes contribute to the babies having episodes of feeding associated apneas or bradycardias. Certainly also, we know that if the baby has abnormal muscle tone, either high tone or low tone, that can impact on their ability, again, to have the endurance that they need or the coordination to be able to effectively latch and suck effectively. Next slide, please. So some cues that we use in the nursery and that we also try to provide guidance to parents around. When we talk about infant-driven cue-based feeding, we're talking about having the infant help us guide us as to their readiness to accept a bottle or the breast, to be able to, that they're able to effectively latch, they're able to effectively coordinate, suck, swallow, breathe without showing us any difficulties. And we also talk about co-regulation. And that's the phase where, while we're looking for the baby to show us cues in terms of what they're able to do and what they're able to handle, is that early on, we don't expect them to be able to sort of pace themselves or self-regulate themselves. So whoever's doing the feeding has to really be looking very clearly and attuned to the baby and know when it's time to give a break. How many times, you can let the baby suck before taking the bottle out, to be able to let the baby catch their breath, or assess when the baby's starting to fall asleep and is not going to really latch well and feed effectively. So when the signs that we look at, the baby's repeatedly pushing the nipple out of the mouth or turning the head awake. The baby is falling asleep and is difficult to arouse. You start to see color changes, hiccuping, gagging, sneezing, yawning repeatedly. The baby is arching back, so that's a stress sign. Fingers spread wide, we call that finger splaying, flailing of the arms, squirming, or the baby becoming limp. A baby with a weak cry, irritable, becoming fussy, and then certainly where the suck is weak or without rhythm. Also, you start to see that the baby may initially have latched well and is actually taking formula in or taking breast milk in, and then you begin to notice a lot of dribbling around out of the side of the mouth around the bottle, or that the baby may start to have again some Brady's or DSATs along with that, and oftentimes the babies will become sort of weak, limp, and sometimes need some, not just the bottle out, but need some stimulation if we're seeing that. Next slide, please. So we're going to shift to talk about human milk feeding in the NICU, but I wanted to just take a minute to see if there are any questions about what we've gone through so far, because it's a lot of information. So we're going to move on to our next poll question as we start this. So again, what are some of the benefits of human milk for the preterm infant? Some of this we discussed the last time, and we've gone over it now too. So the options are fewer infections, improved cognitive development, improved eye development, all of the above. All right, well, while we're waiting for the poll results to come in, somebody had a question about, do we use donor milk? Yeah, we do. Certainly we use it as a bridge to mom's own milk for the babies. They're certainly especially for the very preterm infants, where we really do consider the need for breast milk, whether mom's milk or donor milk, in a sense, a medical emergency, to really start to use the intestine and to be able to provide not only the nutrients, but the immunologic factors that we get from human milk to that infant as soon as possible, so that we will use it as a bridge. And this, wonderful, everybody got this one. So it is all of the above. Certainly in terms of reducing the risk for infection because of the lactoferrin in human milk and the other immunologic properties and immunonutrients that reduce the risk of infection. Human milk has been shown to improve brain development, improve cognitive function, so IQs, when the IQ is tested over time in preterm infants, these babies do better than their counterparts who did not receive any human milk, and particularly in terms of eye development because of ARA and DHA, and all those wonderful arachidonic acids and their associated counterparts in terms of really improving helping to maturize and reduce some of the complications. We also see less chronic lung disease in babies who are exclusively human milk fed. And that too ties in with, again, improved intestinal health, improved brain development. Next slide, please. So I gave away, as part of talking about that, some of what's going to be on the next slide. So we'll go through these a little more quickly. But as I mentioned, human milk contains numerous immunonutrients. And it also, it delivers not only immunologic factors, but growth factors that are important to help the immature intestinal lining in the preterm infant mature. So, and that certainly promotes postnatal physiologic, metabolic, and neuroendocrinologic adaptation. And what that all means is that it really helps not only with the growth, but also the functioning of the intestine. So that's why it's very important and why we try to start colostrum care with as soon as we can. Our lactation and postpartum nurses work very closely with the parents to try to make sure that even if it's just drops of colostrum, we're starting that as quickly as possible. Next slide. So we've mentioned already about the reduced risk of serious adverse outcomes, including the much lower risk necrotizing enterocolitis and infection. It does not mean that in a baby who is exclusively human milk fed, they will never experience necrotizing enterocolitis, which is a severe intestinal infection that can sometimes lead to the need for surgery. But the risk is much, much lower than if that infant receives preterm formula. So again, a reason why we really do encourage the use of human milk, either from the infant's birth parent or from donor milk. Certainly, as I mentioned, fewer infections, less chronic lung disease, improved brain growth, and improved eye and cognitive development. One caveat as it relates to the use of donor milk is that the babies who are getting donor milk do not grow as well as babies who are receiving their mother's own milk or donor milk that has actually been separated so that it's really preterm donor milk. Most of donor milk will actually be donor milk from individuals who've had full-term infants who have provided breast milk for many, many months. And they're donating the residual that's left over. So that tends to be milk that is older in the sense of having lower levels of protein and other nutrient components. And then also with the pasteurization, the freezing that is also done, that also depletes some of the nutrient benefits. So that we do see less optimal growth, but again, that's not a reason not to use donor milk. I think it's an important bridge till you have enough, there's enough mother's own milk, or in the instances where we don't have enough mother's own milk for whatever the reason. It is an important feeding approach rather than just trying to rely on formula. Certainly fewer hospitalizations, overall better health outcomes over time as you follow these children through the first several years of their life. Next slide, please. Okay, so just a few little points about establishing milk supply in the NICU. So early hand expression is recommended as soon as possible, possibly within the first hour, just as a term or near term, or sometimes a late preterm infant who may be 35, 36 weeks without any transitional issues is put skin to skin in the delivery room so that they can nurse within the first hour. The goal is still the same. Lactation support is very important. Provision of a hospital grade breast pump with a double collecting system. There also have certainly preemie modules that are part of the breast pumping system to really try to stimulate, provide enough stimulation to the breast to help with the transition to mature milk production. Combining breast massage and hand expression prior to pumping does optimize milk expression, as well as massaging while pumping, hands-on pumping, are all very important. And Paula Mayer at Rush has done a lot of work in this area in terms of showing that this will actually help mothers come to volume within the first 2 weeks, and that they actually are able to sustain milk production for longer periods. Skin to skin care is very important as well. Next slide, please. We've talked about why human milk alone is not optimal for feeding infants in the NICU. And one of the some of the factors that do contribute to that, certainly we've talked about the nutritional deficiencies that the babies have, that human milk also varies in energy content and protein content, and that preterm human milk has higher energy and protein in the first week or so, and then both term milk and preterm milk, you start to see a decrease, so that by about a month post-delivery, the composition is pretty similar. But in those first weeks, that can be an important nutritional difference. Certainly the stage of lactation, when the milk is collected, the duration of lactation, and also methods for storage and delivery. So as we're talking about the need to fortify human milk for the baby while the baby is in the NICU, it's important, though, that I think we need to think about the words that we use to explain this to parents, because what the parents hear is my milk is not good enough for my baby. And that was something that was brought home to us during one of our perinatal quality collaborative meetings about a year ago, where one of our parent partners was just asking about, just said she always felt this conflict in terms of everybody's telling her that her milk is the best for the baby, but at the same time, the milk needed to be fortified. And as a result, she just kept feeling that her milk was not good enough, as opposed to understanding that once the milk is pumped, all of the things that happen to it, and also why the baby has higher needs than the baby would have if the baby was still in the womb. Next slide, please. So as we talk about transitioning to breastfeeding, feeding at the breast, there's no specific age or weight criteria. It's typically based on a baby's general condition, their ability to coordinate suck, swallowing, and breathing in sequence. We first actually encourage the parents to start with what we call non-nutritive nursing. So empty the breast at the start. It's really to allow the baby to practice beginning to latch and start to suckle without the worry about there being a letdown, and then that sort of causing a little shock to the baby as they get all that milk all at once and don't know what to do with it. Next slide, please. In addition, oftentimes the nursing staff and lactation staff will support the nursing parent through finding what is the optimal position, whether football hold, cross cradle holds, to provide good support for the infant's head and neck while nursing. Nipple shields, oftentimes, especially for the babies who may be smaller, and may have a little more difficulty latching, can be used temporarily after assessment as to the appropriateness. And it's always important we remind the parents to pump after nursing to make sure the breast is fully emptied, even if the baby is nursing and does appear to be getting some milk, as this is important to protect and maintain the milk production and milk volume. Next slide, please. So shifting now, there was a question, I don't know if we can address it
Sure.
now or.
So does the Affordable Care Act pay for the hospital grade pump with a double collection system?
It's in the hospital, the parents have the double collection system. Depending on the pump that the parent gets, in terms of electric pumps, they will cover for a hospital grade electric pump. The specifics of whether you can get a double collecting system, that I'm honestly not sure about. I mean, we usually give the parents the kits, and they use it, and they take them home, so I'm assuming that most are able to get. I don't know in terms of if WIC and how you help assist the families.
Yeah, of course, at WIC, providing a hospital grade pump would be allowable for a parent of a preterm infant.
Thank you. All right, so shifting to some post-NICU nutrition and feeding information. One of the questions that always comes up is, next slide, please, related to the need for fortification after discharge. And that is really dependent on a number of risk factors. We've already talked about the significant nutritional deficiencies a lot of these babies will have, that even with optimal fortification and providing optimal nutrition in the NICU, the babies still are going home lighter in weight and with some ongoing protein and energy needs. The babies who are most vulnerable are certainly those that are born less than 1,000 grams, those who've had prolonged courses of needing parenteral nutrition for greater than a month, whose weighted discharge is less than their birth centile in the growth chart, and also infants who may have at what are called abnormal markers of bone mineralization, meaning that they're undermineralized. And again, these are the babies who may have had evidence of metabolic bone disease or rickets of prematurity. Breastfeeding continues to be recommended and encouraged whenever possible, recognizing that there may be a percentage of babies who may need some supplementation. And the decision about whether supplementation is needed is based again on the baby's growth parameters at the time of discharge, where the baby falls, both in terms of what we call linear growth, so the length as well as the birth weight, in terms of optimizing, again, whether they have evidence of bone mineralization, metabolic bone disease, and if there are other evidence of nutritional deficiencies. So developmental readiness for feeding does vary widely among preterm infants. And the feeding strategies and recommendations for the preterm infant do need to be evaluated on an individual basis. The type of feeding at discharge is generally decided on, as I said, based on the birth weight, the birth centiles, the centile at discharge, and the NICU course. Lactation consultation is encouraged to promote successful breastfeeding. Oftentimes, the babies will really have only had a few attempts at nursing at the breast, or certainly not enough to fully establish full breastfeeding when these babies go home. So continued lactation support, I think, is very, very important after these babies go home. And also for a baby who is still in that transitioning to feeding fully at the breast, it's very important that the parent continues to pump until they have good evidence that the baby really is effectively emptying the breast and the baby is growing well in order to protect the milk supply. So that becomes a very, very important part of the counseling and the ongoing guidance. And I think the partnership with WIC in terms of helping the parent through that, providing that additional support and guidance. In general, the babies go home with an intake of around 120. Our goal is for them to have an intake of around 120 calories per kilo per day. Sometimes it may be as high as 130 to 150 for those infants with significant chronic lung disease or may have congenital heart disease or other signs of, severe nutritional deficiency and suboptimal weight. Our growth goal is to optimally have the baby above the 10th percentile for their corrected age. That's been the percentile that's been most commonly associated with improved neurodevelopmental and cognitive outcomes. So the babies who really are not able to get above that 10th percentile are more likely to have poor outcomes on developmental assessments. We tend to, though, look at the birth centile. You want the baby growing around their birth centile for the vast majority of the babies. We recognize for the babies who are really, really very tiny at birth and well below the curve, our goal is to try to get them as close to the growth curves as possible. So that at the time of discharge, the babies may be going home on exclusive breastfeeding if they're showing us that they're able to take an intake of close to 200 mLs per kilo per day. So typically we say greater than 170 to 180 milliliters per kilo per day, that the babies oftentimes don't need supplementation. But if they're not taking that much, depending on how they're growing and where they are on the growth curves, they may need supplementation. And that supplementation may be with a post-discharge preterm formula. It might be with the use of hind milk. It might be with the addition of standard infant formula. And that's something that really is decided individually by the clinical care team and the parent, really trying to honor the parent's feeding goals. Next slide, please. Okay, so when do we typically stop fortification in the NICU? Usually it's as we're preparing the babies for discharge home. Again, depending on how they're growing, what their growth parameters are and the adequacy of their intake, they may be able to just go home on exclusive breast milk, or for those parents who have chosen formula feeding, they'll be sent home on a preterm post-discharge formula. And that if they are sent home with supplementation or on a preterm post-discharge formula, meaning either nearshore or Enfacare, oftentimes that's continued for up until around 3 months corrected age. Next slide, please. I do want to just take a moment to give one reminder about, because I know that certainly WIC provides and across the country, infant formula is provided as powdered formula in most instances. And particularly for infants who are born preterm, who are less than 3 months corrected age. In particular, there is a higher infection risk. And if people recall when we had the infant formula shortages a couple of years ago, there were several cases of infants who developed infection from powdered formula. Liquid formulas that are sterile because because of the way they're prepared and processed. The powdered formulas are not. So it's really important to go over proper formula preparation for the younger preterm infant who is going home with the parents, in terms of making sure that they're adding the powder to water that's been heated to 150 to, boiled water that's cooled to 150 to 160 degrees, mixing it and then allowing it to cool till it's at a room temperature to feed to the baby, to try and reduce that risk. Next slide. So this is just, again, what I just said. So we can skip to the next slide after that. I'm getting ahead of myself. So as we talk about transitioning from a preterm post-discharge formula to a standard term infant formula, there's there's a lot of controversy still. So you can, depending on where you're looking, what resources you're looking at and what recommendations you're looking at, you see lots of different guidance that says different things. As I mentioned before, a baby who is on the growth curve, has been doing well in the NICU, is taking adequately, greater than 170 to 180 milliliters per kilo per day, of breast milk, does not need to go home on any supplementation unless there's a specific reason. For those infants who are either not growing as well or have, again, some particular nutritional risks, supplementation may be continued, typically between 3 to 6 months corrected age, up to 12 months corrected age based on growth and health risks. So usually the infants who need to stay on one of the preterm post-discharge formulas up to a year corrected are those who have very severe chronic lung disease, may have very severe nutritional deficiencies, have difficulty with weight gain and linear growth, and need that enhanced supplementation. Most of the studies have in fact shown that by around 3 months corrected, most of the babies are able to transition off again to exclusive breastfeeding, if they were having difficulties with growth before, or if they're being exclusively formula fed or combination fed, that by around 12 weeks post-term or 3 months corrected age, you're able to transition off. But I think it really depends on what are the underlying health risks, the associated conditions, where the baby is on the growth curve, and that the growth should be proportionate. So it does become important sometimes to look at, is the issue that there's an ongoing need for calories, or is the ongoing need really for higher protein intake? Because we're very good at making chubby babies. We're not necessarily as good as having them have proportionate length and weight. The boys from the studies that have been done seem to benefit more than the girls. And certainly, at least in terms of early bone health, in terms of bone mineralization, some supplementation has been shown to improve early bone health, but by the time the babies reach around 18 months, there's really not a difference. Next slide, please. And this is just as a reminder in terms of the babies who are at greatest risk in terms of during that transitional period home, for ongoing nutritional deficiencies, suboptimal weight gain, even if they were gaining reasonably well in the NICU. These are the babies that oftentimes may end up readmitted because of either feeding difficulties or poor weight gain. Certainly the very low or the extremely low birth weight baby, the baby less than 1,500 grams or 1,000 grams, small for gestational age, infants who were less than the 10th percentile at birth, babies with significant intrauterine growth restriction. And those again are typically the babies who fall below the 3rd percentile when they're born. And then depending on the adequacy for those babies who are exclusively getting breast milk without fortification, depending on the adequacy of their intake and how well they're growing secondarily to that. Next slide, please. And I think in terms of the information, in terms of additional infants who may have risks, those babies who may need special formulas. So sometimes some of our babies who may have short bowel syndrome or have had a lot of issues with tolerance may not be able to tolerate standard preterm infant formulas, and may even have not be able to tolerate human milk because of either lactose deficiency or protein intolerance, may need specialized formula like Elecare, Neocate, some of the partially hydrolyzed formulas, Alimentum, Progestamil are a few. Infants who require tube feedings at home, and again, a small percentage of babies will go home with partial tube feedings, and they are at particular nutritional risk. The underlying risks associated with any baby who has needed more than a month of parenteral nutrition puts that baby into a very high-risk category. Certainly our babies with extreme medical complexity who've required gastrostomies or tracheostomies. But much more commonly, the baby who really has slow weight gain prior to hospital discharge. So the baby who's gaining only around 2/3 of an ounce a day or 20 grams, at less than 20 grams a day. Next slide, please. At the time of discharge, although we say that the babies need to be able to take all of their feedings by mouth and be showing us that they're able to gain weight, we oftentimes do in those first weeks see a little bit of backsliding when the babies go home in terms of their feeding efficiency, their endurance, their state regulation, their transitioning, from the hospital to home, getting used to a new environment, new sets of stimuli, new routines. So state instability is a concern. Difficulty transitioning from sleep to wake certainly will have an impact on the ability to effectively nipple feed. Physiologic instability in terms of the babies as a result of difficulty with feeding, developing recurrent apnea or respiratory pauses, again, limited endurance, loss or limited duration of suck, swallow, breathe triad, impaired swallowing, and overall poor oromotor control and coordination. Next slide, please. So that this oftentimes, in terms of the guidance that we then give to parents, is that we want them to continue to use. A lot of time is spent helping the parents learn infant-driven cue-based feeding and how to co-regulate their baby's feeds, how to help recognize the baby's cues, when the baby needs a pause, when the baby is fatigued, when the baby needs to take a break. And then to resume the feeding a little later to get the feed completed, to be able to track actually how much the baby's getting, because that helps to provide guidance both when the baby goes to the pediatrician or the family doc, but also when the baby comes to see their WIC nutritionist in terms of getting an understanding of how feeds go. We tell parents that feeding should take less than 25 to 30 minutes. If the baby hasn't completed the feed within that length of time, they need to stop and give the baby a break, anywhere from 30 to 60 minutes. And to really monitor and keep track of that, because it could be that if the baby is really fatiguing, we may need to think of different feeding strategies. It may mean a need for supplementation, even if the baby didn't go home on supplementation. And just in terms of the impact of dysfunctional feeding over time, even when the babies get through the initial period, reach term, corrected age, and get through the first few months, they oftentimes still have ongoing issues. They are 6 more times more likely to have vomiting, more likely to cough when solids are introduced at around 6 months corrected age. Often will continue to have difficulties through 12 months of age or maybe longer as they transition to table foods. And eating problems, as I noted, do persist into childhood with ongoing oromotor problems. Oftentimes these babies will also be very hypersensitive to their environment and may have behavioral and state regulation challenges. And it's an important to also remember that the ability to effectively feed is tied into how effectively a baby can orally communicate. That these kids often, the babies with ongoing feeding difficulties, often have associated language delays as well. So it has multiple impacts. Next slide, please. So these are some red flags that I oftentimes, I think the WIC nutritionists and the staff at WIC will seek information on in terms of, as you're meeting with your clients and discussing how well the infant is doing. Certainly for infants less than 2 months of age, that they're feeding fewer than 8 times in 24 hours, or with fewer than 6 to 8 wet diapers. Certainly, the feeding volume decreasing with age instead of increasing. So again, the infant who is losing endurance, efficiency is not gaining, is not being able to handle the oral feedings as well as one would hope. And then certainly for parents or caregivers having difficulty interpreting or responding appropriately to feeding cues. Next slide, please. In terms of a few more aspects to focus on, certainly assuring that the formula, if formula is being used, is being appropriately prepared in an appropriate dilution, so that the child is getting the calories that are prescribed. And for those infants who are more than 6 months corrected age, assessing their readiness to start solid foods, so complementary feeds. And I think one of the things, a lot of this relates to sort of the developmental age of the infant, because we do need to remember about the feeding readiness cues in terms of having good head control, being able to be upright, having lost tongue thrusting. All of those factors can impede the ability to tolerate foods by spoon. Certainly concerns about cow milk being offered before a year corrected. Next slide, please. So in terms of when to suggest consultation or referral, in terms of when you're seeing the parents, infants who are having issues with persistent vomiting or reflux, loose stools or diarrhea, they're not gaining well, infants whose families are complaining about constipation or discomfort with feeding. So I think that these are all important, and certainly again the one of the critical ones is really the growth assessment, where the child is on the growth curve and if there's evidence of growth faltering or evidence of dehydration. Next slide, please. Sensory and motor functioning of an infant when they go home can have an impact on feeding success. Babies will, in general, have immature state regulation, especially after months in the NICU, which, when you think about the environment in the hospital, and especially in an ICU, it is nothing like what it would be if that baby was still in the womb. So there's all sorts of exogenous stimulation that is really not appropriate for that baby's level of development. So the babies become overstimulated by their environment. They're sensitive to light, noise, touch, visual stimulation, position changes. Some babies will become very distressed and show us lots of stress signs. Other babies may shut down completely. Certainly, we also have associated abnormalities in muscle tone, which are very common in the first few years in preterm infants. And then, as we mentioned, those babies who already have underlying issues with feeding problems, signs of feeding aversion, difficulty transitioning through the various stages of food introduction. And those babies who, again, may either be sensory seeking or sensory avoiding. Both of those set of behaviors can impact the baby's ability to effectively feed and have a pleasurable, enjoyable time feeding. Next slide, please. Just wanted to have a couple of words about complementary feeding. Again, as we've said several times, typically 4 to 6 months corrected age with oromotor readiness signs. I will say that for the very immature babies, so those babies less than 28 weeks, oftentimes you're not able to really properly introduce solids before about 6 months corrected age. Again, a lot of these issues may have low oral motor tone, may still have issues with head control, motor control, posture. And so that you really do need to, certainly one can Typically, we encourage the parents not to offer solids before 6 months. And oftentimes parents will share that they've, tried something by spoon, and you ask how the baby's done, and they just say the baby pushes it out of the mouth. So the baby's not ready, and certainly to continue to encourage human milk feeding through at least 6 months corrected age, and as long as the parent has as their goal. As I noted, there is a tendency towards early introduction of complementary foods that might be attributable, at least partly, to lack of nutritional education given to the family members regarding complementary feeding, and also the potential and their understanding of potential consequences on long and short-term health. It's We're spent a lot of time trying to help parents thinking about if their baby had gone to term, how old would their baby be, in terms of thinking about readiness for advancing through the different stages of development. Next slide, please. We see that in terms of the introduction of complementary feeds, babies who are formula fed tend to actually receive solids earlier. And preterm infants, from studies that have been done, are more likely to receive solids at both 6 and 12 weeks corrected age compared to their full-term counterparts at the same age. And some interesting findings that formula feeding and maternal smoking are also associated with earlier introduction of solids. Next slide, please. A question that oftentimes comes up is in terms of the timing of introducing complementary feeding, as to whether it increases the risk of allergy and atopy. The guidance is actually the same as it is for children who are born at term. Certainly allergenic foods and gluten may be introduced when complementary feeding is started, anytime after 4 months corrected age. And it's also important in these children to avoid delayed introduction, irrespective of the infant's relative risk of developing allergy. Because we have lots of data that shows that there's actually higher rates of allergy, but with delayed introduction of these different allergenic foods. Next slide, please. And just a last comment about transitional formulas. So certainly there will be some infants who at 12 months corrected age are still below the 5th percentile, and will have high nutritional intake needs. So that there are a number of WIC approved infant formulas that are available. Examples are Pediasure, Kid Boost Essentials, Kate Farms Pediatric Standard 1.2, and a relatively new product available in the US, Fortini Infant. They're all designed to provide 30 calories per ounce. Fortini can be used up to 18 months. The others can certainly be continued past that. And then there are always the old standby of mixing half and half with whole milk, which will give 25 calories per ounce. Next slide. Okay. All right, poll number 3. Which of the following is not a reason to refer an infant to their healthcare provider? Choices are refusal to feed, feedings take 15 minutes to complete, stools are dry and painful to pass and occur every 4 days or so, and weight for age decreased 2 percentiles. So again, a reason not to refer. Okay, that's great. So as we said, typically we want feedings completed in less than 25 minutes. So that would be the feeds taking 15 minutes to complete would not be a specific reason or a sole reason to refer an infant to their healthcare provider. I guess we can go on to the next slide, and I'm handing off to Maria.
So we wanted to go through some strategies for supporting breastfeeding at home. So it's important for a provider or WIC to assess infant's latch, sucking pattern, and milk production. We can consider a nipple shield to facilitate latch and effective sucking. However, we do have to be cautious with nipple shields. They can be helpful in certain situations, but they can obstruct nipple stimulation and cause reduced milk supply. So they're intended for short-term transitional use with guidance from a trained lactation care provider, such as the designated breastfeeding expert or an IBCLC. Some other strategies can be to use test weights before and after feedings to gauge intake, to discuss the parent's goals and stress level associated with breastfeeding, and really tailor things, be participant-centered, and then have parents pump after nursing to empty the breast and help maintain or protect their milk volume. If the baby is unable to feed eagerly at least 10 to 12 times a day, and weight and output is of concern, that's when we would want to have the parent pump after feeding. So to go over some of the roles of the different WIC staff, and how we can support preterm families in our different job roles at WIC. So we'll start with peer counselors. Peer counselors making hospital visits can provide support and encouragement, can listen to parents' concerns, affirm their feelings, praise them, and encourage communication with their healthcare team, including the lactation team. They can encourage frequent feedings or milk removal to improve volume and caloric content of milk. And they can encourage the parent to visit the baby in the NICU to provide as much skin-to-skin contact as possible. Once the baby is home, peer counselors can encourage parents to safely hold their baby and provide skin-to-skin. They can encourage frequent milk removal to help build and maintain that milk supply, and they can affirm the parents' feelings, praise their efforts, and remind them that the baby will grow and mature and feedings will get easier as the baby gets older. Peer counselors should yield to a qualified nutritionist, a competent professional authority, or a designated breastfeeding expert for assessment for any concerns with the baby's growth, concerns with milk supply, whether pumping or feeding at the breast. If the baby is unable to latch properly after trying some basic tips, if those are unsuccessful, or if they're having latching problems that persist beyond 24 hours. Another reason to yield would be if the baby's not having enough wet or dirty diapers. Next, I want to talk about nutritionists. So our QNs or our qualified nutritionists and our CPAs or competent professional authorities, the role that they can play in the support of families of preterm infants. So they can conduct nutrition and breastfeeding assessments, develop care plans, and share information. So I'm going to start with assessment. When assisting parents of infants born before term, it's important to assess their feeding goals, the baby's well-being, and the level of support they have to manage any feeding challenges that arise. When working with parents who are expressing milk for a hospitalized preterm infant, nutritionists should assess how the pumping is going, the parent's perception of the amount of milk they're expressing, how the baby is progressing, and the parent's plan for breastfeeding after the baby is discharged. Once the baby has been discharged from the NICU, nutritionists should ask about the healthcare provider's advice about supplementation or fortification post-discharge, and also assess for any issues with overstimulation or other practices that affect the baby's sleep and feeding patterns. Additionally, areas of assessment for the NICU graduate or late preterm or early term infants might include the baby's gestational age at birth, any concerns that might affect breastfeeding, the parent's knowledge about common feeding behaviors of early term infants, skin-to-skin practices, and whether the baby shows appropriate cues to feed. As far as the plan of care, the QN or CPA can determine an appropriate feeding care plan for the parent and baby with input from other WIC breastfeeding staff and, of course, the healthcare team. The plan might include teaching the parent safe ways to feed supplements to the baby if needed, tailoring the food package to support the breastfeeding baby or then the baby's growth, and then appropriate follow-up to ensure that the baby gains weight appropriately. Our QNs and CPAs should refer to a healthcare provider if the baby is exhibiting signs of inadequate growth or development. QNs and CPAs can refer to the designated breastfeeding expert for further assessment if the parent is experiencing signs of low milk production, the baby's at risk for insufficient milk, the baby's not able to latch properly or transfer milk effectively, or the parent needs assistance with feeding the baby with an alternate feeding device. And lastly, the QN or CPA can refer the parent to the peer counselor for ongoing emotional support and encouragement. And then I want to talk about the designated breastfeeding expert. So these are some areas that the designated breastfeeding expert should assess. They're very similar to the QN CPA, but the designated breastfeeding expert's assessment would be more in depth. And so this includes the parent's breastfeeding history, including when they began expressing milk, how frequently they're pumping, and any concerns about expressing milk that occur, as well as their feelings about how breastfeeding is going. They should assess the infant's age and health concerns related to prematurity that might affect the parent's feelings about milk expression for many weeks. So how are you feeling about the possibility of pumping for a long time? They should assess any signs of low milk production, such as poor milk output, if their breasts don't feel fuller before pumping sessions, and any medical conditions that can compromise production, like hormonal conditions, prior breast surgery, or Sheehan syndrome. DBEs can also conduct a breast assessment to identify possible insufficient glandular tissue if the parent has low milk production despite frequent and proper milk expression. And they should consider the parent's reported concerns about milk expression, the parent's reported feeding goals for after the baby is discharged from the hospital, the baby's birthing experience, such as the length of time in the NICU and any problems that developed that might affect feeding, which will help the DBE better understand possible causes of any feeding difficulties. And they should look at the infant's weight and growth patterns and assess for any developmental issues that might affect feedings, like underdeveloped oral structures. And they should assess or observe a feeding session to check the baby's latch, their ability to maintain a good seal at the breast, their sucking rhythm, and how the feeding ends. And then the DBE should refer to the baby's healthcare provider if the baby is showing inadequate growth and development, or if there are other health concerns arise. This is really important, especially for NICU graduates and preterm infants. DBEs can refer the breastfeeding parent to their healthcare provider if health concerns affect their ability to produce sufficient milk. And then lastly, DBEs can assure the parent receives ongoing emotional support and encouragement from the peer counselor, especially in the early days. And I just want to remind you that designated breastfeeding experts and breastfeeding coordinators can refer to the USDA WIC breastfeeding curriculum, problem solving dashboard number 7 for in-depth information on assessing participants feeding preterm infants. And I'll pass it back to Dr. Campbell now.
Thank you so much. We're going to spend a few minutes talking about how we think about monitoring growth. But before that, I wanted to give an opportunity if anyone had any questions, since again, we've covered a lot of content in the past hour. And if there are any questions anybody would like to bring up before moving on.
Feel free to either unmute to ask your questions or put them in the chat.
We'll move on to the next slide while we're waiting. Okay, so one of the important aspects of ongoing assessment and monitoring for babies after they go home from the NICU is remembering that whatever we're doing, whether it's assessing growth, the nutritional needs, developmental milestones, it's important to correct for prematurity. Think about the baby who was born at 28 weeks, so 12 weeks early. They're now 6 months old. They're not going to behave. They're not going to look like a 6-month-old, behave like a 6-month-old. Nothing about them will look like a 6-month-old. So in fairness, we need to give them back that time that they were early. So we do that by what we call correcting for prematurity. So it's the infant's chronologic age minus the difference between the number of weeks they were early. So the way it looks on the slide here, it's the chronologic age minus in parenthesis 40 weeks, which is the considered the full term pregnancy minus the weeks of gestation that they were born at. So again, 40, we're saying 28 weeker, 40 minus 28 is 12. So that's how you would remove, subtract those number of weeks from the infant's chronologic age in weeks. And that's how we typically correct for prematurity when we talk about correcting for prematurity. We typically will correct for the degree of prematurity through about 24 months. There are occasionally some infants that will continue to correct through 36 months of age.
I just want to remind our staff that our NIWIC will automatically do that correction through 24 months for us on our growth charts.
Great, thank you. And in terms of, as we talk about it with parents, because they have so much to remember, and remembering all of these ways that we calculate things, typically we say to them, think about your due date. What was your due date? And when was the baby born, and how many weeks was there in between, so that they're able to think about their due date as really starting as term and then counting from there in terms of what they would expect the baby to be doing, or in terms of development, how to think about what the baby should be eating, and then certainly any other concerns. Okay. So yes, right. So as we monitor growth from birth, during the time the babies are in the hospital, we typically use, most hospitals are using the revised Fenton growth curves. The Olson curves are used by some hospitals in terms of the growth curves, but they have recently developed BMI curves that are now in increasing use. From discharge, for most of our babies, that's around 36 weeks post-menstrual age, so close to term. We continue to use the Fenton growth curve to around anywhere to about 50 weeks. So 10 weeks corrected age. So 50 weeks of age from birth, 10 weeks corrected age. And then we will switch over to the WHO curve, which we use until the babies are 24 months corrected. The Fenton curves in their last revision were updated so that they, in fact, could harmonize, what they call harmonize, or align with the WHO curves, so that you're able to really follow closely and have a better sense of how the baby's growing, that they're really tracking along the same centiles as they're gaining. And then clearly after 24 months, we switch over to the CDC growth curves. Although again, for a small subset of babies, if you are going to correct through 36 months of age, I would just continue to use the WHO curves for that. Next slide, please.
I'll just pipe in that those charts, except for the Olson, are all consistent with what we have access to in NIWIC.
Right, right. And just so you know, the Fenton curves are actually in the process of being updated again. So there'll be a new revision that should be coming out hopefully before the end of the year. So in terms of growth red flags, in terms of our growth expectations, certainly weight loss or a significant decline in percentile ranking, so falling away from the expected growth curve. Excessive weight gain, crossing 2 percentiles in a short period of time, and we've all seen that. Baby's going on, and then suddenly goes like this. Poor weight gain for corrected age, as listed in the table below. So that this gives you a sense, by looking at the corrected age, what's the expected weight gain during those growth trajectory periods of time. And clearly, as we know, that the weight gain certainly slows as the child ages. So that at the point in time they go home, we're really expecting them to gain around 25 to 30 grams a day, or about 6 ounces, at least 6 ounces a week. So if they're gaining less than that, that's an indication, that's a red flag and an indication for close monitoring assessment and potentially for further evaluation. And the same thing within that term to 3 months. Threshold would be 20 grams a day or less than 5 ounces a week, as your sort of red flag. Next slide, please.
All right, it looks like we've got some votes for the right side. Kat, let's go ahead and clear and we'll have Dr. Campbell share what
It would
the
also be, yeah, it'd be interesting, since those that have picked the right are correct. But what about the graph on the left, the growth chart on the left made people say that this was not appropriate growth? If somebody wanted to share what they picked up on that made them say that the growth was inappropriate.
I see Berla saying inconsistent growth
Mhm.
pattern, changing percentiles from Molly.
Right, yeah. So that's great. No, absolutely. If you look at the growth chart on the left, and I know you can't see the pointer, but certainly the baby, when you look at sort of the head circumference and the length at the upper portion of the growth chart, they're fairly stable. I mean, there is some fluctuation, but we also know that sometimes with wiggly babies and not necessarily fully stretching them, the length measurements and the head circumference may not always be as accurate as we like. But certainly as you're looking at the weight, through about 38 weeks post-menstrual age, the infant was growing along the 10th percentile. And then when the baby reaches around 43 weeks, we notice that the baby has the growth is improving or increasing, and we're now at the probably around the 25th percentile. And then when the baby at 48 weeks, 49 weeks is at the 75th percentile. So certainly that baby has cross percentiles, is growing very rapidly. Sometimes the question actually comes up, but if you look at the baby's birth centile, maybe the baby's just getting back to their birth centile. But we know that with the very preterm infants, especially for a baby who started at 25 weeks, that they are going to, although the baby may have started at, say, the 75th percentile at birth, that with the normal sort of extracellular water loss that typically happens, babies lose 7 to 10% of their birth weight in the first week. And, so that has to happen. So that actually, in a way, resets the baby's growth centiles, and you want to see the baby growing along that growth centile where they sort of reset. So this baby, if you look early on, was growing along well from around 25 to about 30 weeks, and then had a period where the growth really slowed down, and then was tracking along a little above the 10th percentile, probably around through the time of discharge. And then the other 2 visits were probably high-risk infant clinic follow-up. But certainly you could see the baby's weight taking off dramatically, and it'd be important to explore with the family what the baby's being fed, how the baby's being fed, and just the speed with which the baby's gaining weight, especially when you're not seeing commensurate increase in head circumference and length. Because again, this is the baby that we make chubby without necessarily having good linear growth, and linear growth that we need to, that we need in order to be able to have good brain growth and optimize outcomes. Okay. So I think we're gonna, so this was great. Everybody got this one. There are others that you can look at on your own. and go through, but that was terrific. All right, so now we just wanted to finish up talking a little bit about support and resource needs of preterm infants. Next slide, please. So it's important to think about what's the infant's transitional, where the baby is in their transition from life in the NICU to home. In the first 3 months, the focus tends to be, as with a lot of new babies coming into a home, on feeding, weight gain, elimination, sleep. But in addition, for the preterm infant, the adequacy of breathing. Parents are always very afraid of how well the baby's breathing. For those infants who may need to go home on medications or with medical technologies, partial tube feeds, on a home monitor, there are a number of different additions that can make having the baby transition or impact the transition home, and add heightened stress to families. Also, in addition, as we've talked a lot about, the baby's state regulation, their ability to handle a new environment. And that can actually impact infant caregiver interactions, because particularly for a baby who shuts down if they're overstimulated, the parent or caregivers may feel that the infant doesn't like them, and doesn't, is not, that they're doing something wrong in terms of their inability to engage the infant. What do we typically do when we want to try to engage with the baby? You jiggle the baby. So if this is a baby who's sensitive to stimulation, that's only going to set them off and they're going to start to cry. So it certainly, you can have a lot of negative feedback that happens as this baby is just trying to transition. I always tell parents that, the baby needs a period of recovery from being in the hospital with all the lights, the noise, the poking and everything. It just needs some time to recoup. Also, in terms of sort of navigating life outside the hospital, going out, parents are oftentimes, hesitant to take their babies out, to have them around a lot of people. So that leads to social isolation. And they're oftentimes, although certainly we know in some families, there may be many preterm infants, most families do not have experience with a prior preterm infant. So there is a significant degree of isolation. And when the baby goes home, although they're happy to get out the NICU, they also lose that social safety net in terms of people who understand their stresses, what their worries are. And they lose that sort of that intimate support that they were getting. Certainly the need to navigate multiple doctor visits, not only the pediatrician or family doc or nurse practitioner, but high-risk infant follow-up clinics, pulmonary clinic, eye clinic for retinopathy or prematurity. So all the different complications can really add to the stresses that families have. Next slide, please. As we think of when the baby reaches around 3 months corrected, so 3 months to 3 months after discharge to a year, again, still focus a lot on feeding, weight gain, catch-up growth, overall general health, ongoing concerns around self-regulation, the ability to handle stimulation and social interaction. Certainly, we see evolution in the transient muscle tone abnormalities, which can continue to impact sleep, feeding. Some of these babies will have positional plagiocephaly, some may need helmets. That certainly can impact milestone accrual and interfere with feeding and growth. And also that the child is developing corrected age-appropriate milestones. Next slide, please. As we transition into the toddler and early childhood years, there tends to be a shift with greater focus on the developmental milestones. So motor milestones, communication and language skills, sensory issues that may be either emerging or progressing. Catch-up growth continues. This is a period of time where if the child hadn't been identified with specific early intervention, eligibility, service needs earlier, this is oftentimes when we begin to see that when the language and communication delays become more obvious, and there are persistent delays in other developmental domains. Next slide, please. an important point is during this period of time, autism screening. We know that autism rates certainly nationally are increasing among all children, I think related to better attention and focus and screening. But among preterm infants, the rates of autism are about 25% higher than in children who were born at term. So it becomes very important that autism, that screening be conducted. One of the challenges sometimes, though, in terms of making the diagnosis of autism in a preterm child is the behavioral difficulties that we see in preterm children related to attention difficulties, hyperactivity, some social immaturity, really can seem very similar to the presentation in terms of the symptomatology that you see with a child with autism. So sometimes it's difficult to distinguish prematurity from true autism. But it is something to be mindful of because that can certainly impact effective feeding, engagement, growth as well. Emerging learning difficulties, ongoing sensory issues, and social immaturity are a concern. And the last point to cover as we finish up relates to the importance of every child having a medical home. This is a concept that's been long established in pediatrics, but we still see that in many high-risk children, particularly in preterm children, they really don't have a medical home. What is a medical home? It's a primary care setting that focuses on providing comprehensive and high quality care, where again, the pediatrician, family physician, nurse practitioner, physician assistant, whoever is heading up that child's primary care, provides care that's accessible, family-centered, continuous, coordinated, compassionate, and culturally effective. So it is something that when you're meeting with families, if you identify that the child doesn't have a medical home, and that really means an established single medical provider. Certainly there are children who attend clinics, but every time they go to the clinic, they see somebody different. That's not a true medical home. Unless it's really a team-based approach and everybody in that practice knows the child, knows the family. So it's something that we are trying to encourage everybody who interfaces with any of our graduates to try to assure that the children have that. We try to establish it at the time the babies go home from the NICU, but sometimes with changes in insurance, families moving, just all sorts of unforeseen circumstances, that what we set up is not actually what happens. I think we are done. There's one more slide, but I think we've shared a lot of this throughout the full conversation about the rationale for why these children, most importantly, needs a medical home. But every child deserves a medical home, as does every adult.
Thank you so much, Dr. Campbell. So folks can put their questions in the chat if you would like. We will stay on for a few minutes to answer questions. For those who don't have any questions, you can complete the evaluation in the WIC resource hub. We will drop some instructions into the chat. There is also an optional evaluation for those of you who are registered dietitians or dietetic technicians registered. You can provide your feedback to CDR if you would like with that optional link that Kat dropped. But if you would like your certificate for attendance today, you do need to complete the evaluation in the hub. Evaluations are anonymous. And then your certificate will become available in the hub. The evaluation will close after 24 hours. So if you don't complete the evaluation within that time frame, you won't receive your certificate. So please do that within the next 24 hours. Thank you all so much for coming. You are welcome to click that leave button if you would like, or you can stay on with us if you have any questions. I know we do have one question that we didn't get to. From Dahabo, we use goat milk in our Somali community if mom isn't able to breastfeed. What does the research say about offering goat milk for preterm infants? Is it optimal with combination of breast milk? Also, is it offered in the hospital?
Thank you for the question. Goat milk is not offered in the hospital. In terms of the American Academy of Pediatrics has provided some guidance around the use of feeding goat milk. We don't have good data in terms of the in terms of how appropriate it is for preterm infants. Most of the studies that have been done have really been with term infants. Certainly, we recognize that some babies are some families will opt for goat milk in lieu of other milk for their infants if there's insufficient breast milk. But it's not at this point part of the standard recommendation in terms of options for preterm infants.
I do want to share too, we do offer goat milk as a substitution for cow's milk in our WIC food packages, but not in the infant food package. So only on the women or child's food package. And then you would also want to make sure that the participant is able to redeem those benefits. Maybe help them find a vendor that accepts WIC and also carries goat milk, since it's not required to be carried by vendors. Any other questions from folks? You can unmute or you can drop them in the chat. I see some nice chats coming in. Thank you all for attending. Oh, Maria's saying, is there any mental health support for moms after discharge?
We could always use more. You know, I think depending on where the parent received their care, the NICUs are now doing more mental health screening within the NICU, certainly as part of the initial postpartum assessment, that there is a component of screening that's done, and certainly within the pediatric setting. So in those first visits, evaluating the parent for perinatal mood and anxiety disorder is important. The resources are variable and limited. I mean, at Einstein, we do have perinatal psychiatry that's available to us, but again, it's limited. So we could use more, but yeah, we are trying to focus more on screening and then making referrals for mental health support, because we know, you know, the impact on families, in addition to the post-traumatic stress disorder that we see in up to 40 to 50% of our parents from just the nightmare of having a baby in the NICU.
I want to remind you all too that Postpartum International does offer online support groups, as well as a number of other resources. We'll drop a link in the chat for their support groups. They have groups that are tailored towards various situations, right? They have ones for LGBTQ moms or families, have for folks experiencing loss. So there's all different groups, multiples. So that might be a spot to point people towards as well if they're looking for some support. If there are no other questions, we'll go ahead and close out the training in a minute or so. Please do complete your evaluation. We hope to see you at another training again soon.